evening and welcome everyone to the DOS-PEP program. And as you all know, we are currently in the Strabismus and Neuro-Ophthalmology module. And today is the 18th lecture, and we'll be discussing a very important topic, that is clinical workup of a case of optic neuropathy and diagnostics. In the previous lectures, we have discussed about the anatomy and physiology of the optic nerve and the visual pathway. And today we have an eminent speaker, Dr. Sonali Gupta, who will be talking about the workup of a case of optic neuropathy. We'll be having Dr. Gunjan Saluja, who is a consultant in strabismus oculoplasty and neuro-ophthalmology services, and she's done her post-graduation and senior residency from AIMS New Delhi, and she's also an assistant editor at IGO, who will be discussing about the presentation with Dr. Sonali, and Dr. Abhipsa Sharma and Dr. Anita Gangar will be also joining us for discussions. Dr. Sonali Gupta has done her post-graduation in ophthalmology. Beyond that, she is also awarded with the prestigious FRCO of London, FRCS Glasgow, MRCS Edinburgh, FICO, and DNB. She is currently working as an assistant professor at Lady Hardinge Medical College in New Delhi, and she's trained through international fellowships in pediatric ophthalmology and neuro-ophthalmology in UK at Birmingham, and she's also an examiner for FRCOPT and FRCS exams. So all of you who are planning to appear for these exams, you may be meeting her in your exam stations as well. And she's a member of the Neuro-Ophthalmology Subcommittee of the Royal College of Ophthalmologists and is actively involved in research, publications, and academic teaching. With that, Dr. Sonali, I would like to hand over the podium to you for your talk on workup of a case of optic neuropathy.
Thank you, Dr. Pranita, for the introduction. So I'll just share my screen. So is my screen visible?
Yes, ma'am.
Okay. So as we all know, optic neuropathy is a dysfunction of optic nerve in which there is loss of visual acuity, color desaturation, field defects, as well as usually a presence of RAPD. It is more of a clinical diagnosis only supported by ancillary tests. Hence, the point of today's lecture is how do we do a clinical diagnosis based on history and examination followed by investigations. So broadly, we can classify the optic neuropathies into, based on the mechanism, into inflammatory, ischemic, compressive, toxic nutritional, hereditary, or traumatic. So each type has its own characteristics, which we can bring out to some extent on the history and examination. So why a good workup matters? Because many of these causes are reversible, like inflammatory and compressive, which if treated timely can result in reversal of the visual loss. Also, some require timely systemic therapy like giant cell arteritis or other autoimmune conditions, sarcoidosis. And a systematic approach ensures that no etiology is missed and timely treatment is instituted. So, based in the history, as for all diseases, we focus more on the onset and progression, the type of visual loss, how it progressed, was it associated with any pain, the laterality, the associated symptoms, and systemic history, because 90% of the localization we can derive only from a good history taking. So, coming to what points to actually elicit when a patient says, I cannot see clearly, that could mean a lot of different things. So, we first have to ascertain whether he means it is a uniocular loss or a binocular loss, more for distance or near, associated with any pain. Sometimes patients with papilledema can just present with transient visual obscurations. So we do need to ask them whether the vision stays the same all the time, or do they notice some episodes of blurring while they are bending forward or cuffing, which comes back to a normal level. Was it acute or was it a gradual onset? Has it been progressing or static? Because so if we take up each of these points separately, so if it is a monoocular visual loss, then we think more of a localized optic nerve pathology on one side. But if it is binocular, then sometimes lesion can either lie posteriorly or they are more commonly associated with the systemic diseases like a toxic nutritional. Then painless or painful. Pain shows some inflammation is going on, so a neuritis is happening. So it points us more towards a typical optic neuritis. Then transient obscurations we discussed, it's more in terms of papilledema. And is it progressive or static? Usually vascular causes are static. They happen suddenly at one point and then stay the same and or change over time. But progressive ones are mostly inflammatory and which require a quicker workup and quicker treatment. So based on the temporal profile, if it is very acute, then usually it is a vascular cause or sometimes inflammatory. If it has happened over days to weeks, then compressive or an infiltrative pathology should be suspected. And if it has been very slowly progressive over a long time, then it usually signals maybe it is a toxic, nutritional, or a hereditary cause. So all these history taking do point us towards the etiology. Then, as we discussed, pain on eye movement signals neuritis, but headache, scalp tenderness, which is very important to elicit in the elderly, can signify giant cell arteritis, which can even be life threatening and involve the other eye very quickly. So, we need to act fast. Usually, the painless causes are ischemic, toxic, hereditary, many times even compressive lesions. So, we do need to look into that. Color and contrast, sometimes patient himself can come out with it. He reports that I see the colors washed out with one eye when I look from the other. They are an early sign, and even before visual blurring, color vision can drop. So if a patient says it is looking washed out, we do need to pay attention and look further. So a good drug and toxin history, because ethambutol, isoniazid, the anti-tubercular treatment have been shown to cause bilateral optic neuropathies. Other drugs may also be associated as well as tobacco, alcohol addictions. And for ischemic cause, we do need to take the history of phosphodiesterase inhibitors like sildenafil because they cause a sudden drop of blood pressure and are known to cause non-arteritic ischemic optic neuropathy. So if we do find that he is on any of these agents and it fits into the general picture of a toxic nutritional optic neuropathy, then we do need to prod further into the dose, duration, and determine if we can switch the patient from that agent to something else. So a good systemic history and family history because diabetes, hypertension, sleep apnea can cause the ischemic optic neuropathies. Autoimmune conditions, neurological symptoms, malignancies, they can also present with optic nerve involvement. And family history is important in the hereditary causes like a Leber's dominant optic neuropathy, which usually show a mitochondrial inheritance pattern. So, based on this, again, we are trying to narrow down the etiology. So, there are certain red flags in history which we need to be careful about and do a further urgent evaluation if any of these is present. So, a bilateral simultaneous loss usually indicates a central or a systemic process rather than a localized optic nerve lesion. So, again, we might need an imaging, we might need a good history taking, if the loss is progressing beyond 4 weeks. So a typical optic neuritis, what we call, which is happens due to demyelination, multiple sclerosis, usually worsens in the initial 4 weeks, then stabilizes and starts improving. But if there is a gradual worsening beyond this period, then it can indicate other more sinister causes like a compressive infiltrative lesion. And we mentioned that it can be a painful cause in a typical optic neuritis, but a pain which is be out of proportion to his symptoms, which is very severe. It can also signify compressive lesion, which might be involving the other nerves causing these pain. And if we have decided to start steroids, thinking it is an inflammatory cause, and he is not responding, then still again we need to look into other causes. So coming to examination, so a complete ophthalmic examination, like for any eye disease, is important where we check the visual functions comprising not only the visual acuity but also the color contrast. If he reports any changes with in the near vision or any changes he reports with temperature, he says when I go to a hot place or I exercise. Sorry for the interruption. Am I again visible, the screen?
Yes, ma'am, you're visible. If you could just share your screen once again.
I'll do that. Is it visible now?
Yes, yes, ma'am. We can hear you, and this it's in full screen now.
Okay. So after doing the visual acuity, we also need to check the pupils and a comprehensive ophthalmological examination. I'm really sorry, something happened. So visual acuity and pinhole testing and the other optic nerve functions comprising of pupils, optic disc examination, color vision, contrast, visual fields and imaging form a complete part of the ophthalmological work. So coming to the pupillary reflexes, we do need to check for RAPD, which is usually the hallmark of unilateral or asymmetric optic nerve lesions. It is detected using the swinging flashlight test, and we can even grade it using neutral density filters. So usually lesions posterior to the lateral geniculate body don't cause an RAPD. We can even grade it to see the severity of the asymmetric lesion. Coming to the color vision and contrast, they do help us in picking the earliest signs of optic nerve dysfunction, and they can precede a measurable visual field or a visual acuity loss. So they are very sensitive to checking the early stages. A good fundus examination, especially looking at the optic disc, because disc gives us a clue in what is going on. If there is no change in the optic disc appearance, it usually suggests retrobulbar optic neuritis, which is a very common feature of a typical optic neuritis, that is the one associated with multiple sclerosis. In case there is disc swelling, then vascular causes, inflammatory or infiltrative diseases need to be kept in mind. A pallor suggests either an old optic neuropathy or even the toxic nutritional types present with a temporal disc pallor. Cup disc is a characteristic of, as you all know, glaucoma or even compressive lesions. So when we look at the optic disc edema, there are certain mechanical and vascular signs which give us a clue on what is going on. So there could be a mild loss of cup, elevation of disc margin, just a subtle nerve fiber layer edema, or a very florid disc edema with all the vascular and signs including peripapillary hemorrhages, cotton wool spots. We can grade the disc edema based on the modified Frisson grading. So this signifies the severity of the disease process. We need to differentiate between a true disc edema, or papilledema, or a pseudopapilledema, because many times these appearances are confusing. But just an isolated fundus picture, looking at disc edema, we cannot pinpoint the cause. So comprehensive workup is essential. So depending on how the pupil was, whether the optic cup is obscured, how the vessels are. We can even do an angiography to look for a true disc leak, which would be there in a true papilledema, and as opposed to no leakage in a pseudopapilledema. Some frequent causes of pseudopapilledema could be a optic disc drusen, apart from the hypermetropic disc, myelinated nerve fibers, a tilted disc, or a hypoplasia. So if we come across a disc pallor, which could again be primary, secondary, or consecutive, so we that again points us towards what is could be the cause. So primary could be caused by a compression of the nerve, the hereditary or the nutritional optic neuropathies. Secondary could be following a chronic disc edema, chronic papillitis, or a previous vascular cause which has caused a ischemic optic neuropathy. Consecutive could be due to other fundus diseases. So just looking at disc pallor, we cannot say it is a case of optic neuropathy. Looking and doing a careful fundus examination can give us clue of what might be going on. So again, if the onset has been sudden in a patient with disc pallor, it could be traumatic optic neuropathy, which causes a sudden vision loss following a history of significant trauma, as well as associated with disc pallor. It could also be an arteritic type of ischemic optic neuropathy, which causes a pallid disc edema, sometimes maybe a bit old, so it could only cause a pallor without any significant edema. If it has been a gradual loss, then it could be nutritional, toxic, or compressive. Again, based onset, then progression. Compressive, toxic, post-optic neuritic, labors, they can all progress over a time, and we take other drug histories. So after this, we check the visual functions, then we looked at the fundus, then we need to do a visual field. Especially confrontation visual field is a very important clinical technique to possess before being able to organize a formal Humphreys visual field. You can get a quick clue in the clinic itself on where the lesion could be. So we can correlate the type of visual field defect with the basic anatomy of the visual pathway. So if it is a central scotoma or a junctional scotoma, that is one eye involved completely, while the other eye only has a peripheral superior defect, it signifies the lesion could be in the optic nerve or just prechiasmal where the von Willebrand knee comes. If then as we go posterior, both eyes become involved, and in case of a heteronemus defect, it signifies a chiasmal lesion. As we go even posteriorly, and the defect becomes homonymous, that is either the left side of both eyes are involved or the right side, that signifies a lesion posterior to the chiasma up to the occipital cortex. So just picking up a gross visual field defect can give us an idea whether we are actually dealing with an optic neuropathy, which is the lesion and before the chiasma, or we are dealing with something which can be posterior in the visual pathway and needs an imaging to see whether it is stroke, demyelination, or what else is going on. So, as we discussed, based on the pattern of visual fields, it could be a central centrocecal scotoma signifying the optic neuropathy. It could even be just an enlarged blind spot which happens in papilledema. An altitudinal field defect signifies an ischemic optic neuropathy. Bitemporal or homonymous again show us a posterior cause. So, different patterns of field loss help us to narrow down anatomic location. Then we need to look for systemic signs. We can palpate the temporal artery in patients which are clinically suspicious of a giant cell arteritis. We could do a systemic examination to look for some rashes if we are suspecting sarcoid, SLE, and other neurological deficits could be there in demyelinating symptoms. So a thorough systemic examination is also a part of good clinical workup in optic neuropathy. What are our diagnostic goals? What all we have discussed till now. First, whether the lesion is really in the optic nerve or is it somewhere else in the visual pathway. Second, after we have localized where exactly in the optic pathway it is and whether it is in the intraocular part of the optic nerve, so we see an actual disc edema, could it be papilledema, or it is intraorbital or further behind. Then, if we can reach the cause, it helps us to act swiftly, and it also helps us to assess the prognosis and tell the patient about the expected visual outcome and recovery potential. So, after a thorough clinical examination, we come to the investigation. The most important investigation to document and to see what is going on and prognosticate is OCT these days. Uh, Apart from neuroimaging, which can be needed in selected cases, which we'll discuss further. So OCT does show us two parameters which are important to us for evaluation of optic nerve head. One is the RNFL thickness and other is a GCC layer, the ganglion cell complex layer. So both of them have their own value. So like in this case, this is a case of multiple sclerosis, diagnosed multiple sclerosis presenting with a typical optic neuritis of the right eye. So at presentation, there was a mild temporal disc pallor because the visual loss had been going on for a while. On OCT, it correlated with the loss of retinal nerve fiber layer in the temporal quadrant of the right eye. So it correlated with the disc pallor. So this is straightforward where we are just correlating with RNFL. But why do we need to do a ganglion cell layer analysis in some patients, and which provides us a very important prognostic tool? So this is a patient who presented acutely with disc swelling. The pallor had not set in that markedly, and it was an acutely swollen disc. So at presentation, the RNFL thickness was fine in all the quadrants, and so was the ganglion cell complex thickening, because he came soon after the loss of vision happened in one eye. 2 weeks follow-up showed that the RNFL is still thick because the edema had not resolved. So the RNFL thinning could not be appreciated. It was masked by the edema, but the ganglion cell layer thinning had started to set in, which shows that there was a loss of nerve fibers happening actually, which was not picked up only in the thickness of RNFL. Over a few more weeks, as the edema subsided, the thinning of RNFL started becoming obvious in the thickness map as well, but the giant ganglion cell complex thinning persisted, which was the pattern in the long-term follow-up also. So it took time for us to appreciate the RNFL thinning alone, while the ganglion cell complex thinning had set in very early in the disease. So this shows us that it is not just a disc edema, it is affecting the visual functions as well, and we can prognosticate regarding the chances of recovery and how fast we need to act. This is another patient showing that while the RNFL thinning is there is also a significant ganglion cell complex thinning even in the right eye, and left eye shows thinning in both the maps. So we do need to do both GCC and RNFL thickness in all the patients suspecting optic neuritis. So, what brings us to the thought that it could be atypical, and we do need to image further and look into more causes rather than just label it a typical multiple sclerosis related optic neuropathy. So, if the patient has some factors suggesting immunocompromised status, some history of rheumatological or oncological diseases, then we do need to look further rather than just labeling it typical. On examination, if we see the eye, it has a severe vision loss to the extent of no PL, which is very unusual to have in typical cases. It is completely painless or there is extremely severe pain. If there are associated macular changes or uveitis, they all signify that it is something atypical. And again, the clinical cause, vision loss progresses beyond 2 to 4 weeks. There is persistent pain for a long time, and no visual recovery starts even after 4 weeks. So, all these tell us that there could be something more going on. It is not just a typical optic neuritis, and we may need to do a neuroimaging for the blood test to look what is going on. So MRI brain and orbit with contrast is the imaging of choice to be ordered in all cases where we want to look further into the cause. So it can either show an enhancement of the optic nerve, suggesting an inflammatory or a demyelinating cause. Sometimes we do end up finding a compressive pathology, especially if it is around the orbital apex syndromes. So they present with optic neuropathy, other external ophthalmoplegia, and the mass can be picked up on imaging. Characteristic finding of the demyelinating plaques can be seen in multiple sclerosis. So if the age is atypical, for that is, it is a very young or a very old patient. If there is bilateral involvement, progressive disease, poor recovery, the MRI brain and orbit with contrast is essential. So here we can see that there is enhancement, post-contrast enhancement of the left optic nerve substance. This part is just the CSF space running, which is the normal CSF space around the optic nerve sheath. But here the substance of optic nerve also shows an enhancement. So having a long segment enhancement or other features like plaques or something in the orbital apex which may be compressing is very important not to be missed. So in case of traumatic optic neuropathy, the investigation of choice is a CT orbit, because we need to see whether any bone piece is impinging, which can be a reversible cause, or any other fracture, calcification, canal narrowing is there. If we are still not sure what is going on, sometimes we do need to take the help of VEP and FFA, which is not very routinely needed because once we know the visual functions are compromised, VEP is usually the latency and amplitude show changes. But they are helpful either in bilateral cases where you are not appreciating RAPD in children, in cases of unreliable vision. Fluorescein angiography can help to differentiate between true disc edema and pseudopapilledema. So the lab investigations are important to see the cause. In demyelinating diseases, these days getting the aquaporin 4 antibody, anti-MOG antibody is essential because they need specific immunosuppression for a long time as opposed to the typical multiple sclerosis demyelination where maybe a course of corticosteroid suffices if it is the first presentation. But the MOG and NMO cases keep recurring, so we get a blood test done. Other bloods for ESR, CRP, glucose lipids, especially for the vascular AION and NAION causes. If we are suspecting autoimmune conditions, then ANA, ANCA, serum ACE for sarcoid, with associated uveitis is there, or 7 nerve palsy. Infectious causes to be ruled out with VDRL, HIV, Lyme, nutritional causes with B12 folate, and if we are suspecting a mitochondrial inheritance, Leber's optic neuropathy like picture, then we can send for the genetic testing to pick up the specific gene causes. Now, lumbar puncture and CSF analysis may also be needed to look further into the cause where and to confirm the findings, especially of multiple sclerosis, or to pick up any raised ICP to check the opening pressure, inflammatory and infectious sign. So cell count, protein level, and oligoclonal bands are tested in the CSF in conjunction with a neurologist. So, what all we have discussed, we realized that a good history taking, a thorough examination, performing imaging like OCT and visual fields by confrontation, as well as a automated perimetry to confirm the findings, neuroimaging, MRI, brain and orbit with contrast, supported by the lab test, do help us reach a diagnosis and start timely treatment. So to summarize what we have done, so if we get a typical clinical presentation of a 55-year-old diabetic presenting with a sudden painless loss of vision, affecting the lower half of his visual field. So the key points in the history itself are showing us what is going on. So the age, it is a middle-aged person. He is a diabetic, so he has systemic risk factor for a vascular etiology. As we mentioned, the pattern of vision loss is sudden. Sudden causes are usually ischemic vascular, which happen at one point and then stay there before improving after maybe improve or worsen further later. It is painless if it is ischemic, not inflammatory or anything else. And the other thing is visual fields affecting the lower half. So it is an altitudinal field effect. So these 4 5 points, even before looking further into his fundus or other formal tests, we can pinpoint that it is probably a case of non-arteritic ischemic optic neuropathy. So then for the management, we do advise the control of the systemic risk factors and to reduce the risk in for, the fellow eye and a regular monitoring for improvement. Then coming to the other presentation which could be there, where again we could have a good clue only from the history, is a 30-year-old female, so it is a younger patient. There is pain on eye movement signifying an inflammatory demyelinating cause, which is a neuritis, and disc appearance normal, showing it is a retrobulbar neuritis. So this typical presentation, and if we go further and get MRI confirmation of demyelination, this shows that it is an optic neuritis. So based on whether it is typical and discussion, we can start the appropriate treatment timely. Again, a typical history of an elderly patient with a pale swollen disc, pain, temporal tenderness, severe headaches. Getting bloods done showing a massively raised ESR can point out towards a giant cell arteritis, which is a very ocular emergency which needs to be dealt very swiftly. And as IV steroids need to be started even before you can organize a temporal artery biopsy or further confirmatory test. So this shows the importance of a very good history taking, which can lead you to a diagnosis even in a early stage. So as we discussed, it is the same again that history, examination, fields, OCT, imaging, labs help us reach a diagnosis and start timely treatment. So, what are the common pitfalls we can face? Assuming that if the patient says there is a vision loss, we just assume it is a retinal or a macular cause and don't look further into the optic nerve head or think about that. Then we even if there are atypical signs, we skip the neuroimaging. Then we can sometimes miss very important causes which can even be life threatening. Ignoring whether it is bilateral, unilateral, and forgetting to get ESR in the elderly. Although giant cell arteritis is less common in the Asian population, but still, if it is there, it can be life threatening. So we do need to keep it in mind always. Thank you.
Thank you, ma'am, for the wonderful lecture and for covering almost all the points of neuro-ophthalmic evaluation. So there are a few questions and a few points which they want to know about. First is the role of ultrasound in neuro-ophthalmic imaging, in neuro-ophthalmic diagnosis.
Okay. So, an ultrasound can be used to differentiate the, as we said, the pseudopapilledema causes mostly the optic disc drusen. It shows a very good spike if there is a drusen present. Sometimes it is associated with vitritis, so to the optic disc swelling, which could be in cases of sarcoid or other inflammatory causes. So we can document that as well and monitor the resolution. Also, ultrasound of means B scan is fine, but temporal artery ultrasound is another helpful tool if we are suspecting a giant cell arteritis.
Yes, and one more thing is that in IIH, you can have the optic nerve sheath diameter test. So you can, use ultrasound for that. And as you covered very well about the OCT also. So in pseudopapilledema, if there is a disc drusen, you will get a hyperreflective imaging in OCT.
Right.
Again, so there is also increasing, I think the postgraduates, if they are keen to know more, so there is also an increasing role of OCT angiography in neuro-ophthalmology. So they can know that for extra points, especially in ischemic optic neuropathy. I think they should know about that also. So, if you can, ma'am, they just want to ask what are the differentiating features of disc edema and pseudodisc edema
So,
clinically,
yeah,
clinical
so
examination.
clinically, you do need to look carefully at the surrounding area of the disc, the RNFL opacification, whether there are any patterns line, whether you actually see a loss of the cup, the vessels are dilated. They are all features of a true disc edema. The pseudo edema usually gives either a lumpy, bumpy appearance. The nerve appears to be raised, but the vessels, the surrounding area, RNFL edema, that is usually missing. So it can have a confusing appearance only clinically. So as Dr. Gunjan said, it can be supported by the OCT and ultrasound, the other imaging findings to really be sure what we are looking at rather than just labeling it hastily.
Yes. And then what's the role of contrast sensitivity in diagnosis?
So the color vision as well as contrast is lost at an earlier stage than the actual visual acuity. So it helps us to diagnose early as well as monitor the recovery because contrast comes back a bit sooner than actual visual acuity, which we can appreciate.
Yes, exactly. So one more question is there. What are the blood investigations which you would advise for the patient of optic neuritis that works in your OPD?
So, if we are suspecting a demyelinating cause after narrowing down on the history and examination, so as we said, the antibodies, anti-NMO and anti-MOG are an essential diagnostic tool these days. And then further autoimmune profiles, infectious causes, the genetic test if indicated. So, based on what we are suspecting, the basic bloods for vascular causes, the blood sugar. Uh, And anything to rule out tuberculosis, infections, VDRL, HIV, we need to go according to what our clinical suspicion is.
And any specific protocol for MRI that we have to advise for the neuroophthalmic disorders?
So we want a fat suppressed images especially, and MRI always needs to be with contrast of both of the brain and orbit. With fat separation, that is usually what we request.
Yes, so I think that covers almost all the points. And thank you, ma'am, for the wonderful lecture.
Thank you, Dr. Gunjan. It was really nice to interact, and it keeps us updated as well.
Pranita, ma'am, are you there? Dr. Pranita, ma'am, I think she's there. So, this is the certificate of appreciation, ma'am, that you'll be getting in the annual DOS conference, the FAME certificate that will be given to you for the very nice lecture and very well covered points about the neuroophthalmic examination. Thank you, ma'am.
Thank you.